Next, I'm joined by Dr. Phillip Barter, Professor of Medicine at the University of New South Wales in Sydney, Australia. We cover HDL therapeutics, lipid management today, unanswered questions and unquestioned answers. So, Phillip, welcome to ACCEL. Your expertise in the area of lipids is well appreciated, and I think your theme this meeting is on HDL. We've got a lot of talk about LDL, so why don't you tell us a little about your presentation yesterday and some things about your thoughts about HDL and the ability to try to raise the HDL levels.
As you say, LDL is the flavor of the decade, and there is terrific work going on, but HDL is being forgotten. People are saying it's dead. It's certainly not dead. We have much we need to learn, but the very first point to say is that the cholesterol in HDL does not protect. If HDL protects, it's the particle that protects. It's the function of HDL. And there are a number of facts that we know with absolute certainty. The concentration of HDL cholesterol is a good marker of whatever function if HDL protects, because the epidemiology is robust, almost no exception. The lower the HDL cholesterol concentration, the higher the risk of having a cardiovascular event. We also know that HDL has many functions with the potential to protect. It promotes the efflux of cholesterol from macrophages. It's anti-inflammatory, it's antithrombotic, it's antioxidant. It promotes endothelial repair. It can even stimulate the pancreatic beta cell to synthesize and secrete insulin. We also know that in animal studies, both mice and rabbits, increasing the HDL by genetic manipulation or even infusion of HDL really reduces, almost abolishes atherosclerosis. So the evidence is robust. The human genetics is very confusing, but that does not relate to function. But our big problem is that we've had 2 recent niacin studies that have failed and 2 recent CETP inhibitor studies that have failed. And there are reasons. The niacin studies, one of them was seriously underpowered and we can't draw any conclusions one way or the other. And the other, the big study, the HPS2 Thrive, was done in people whose baseline LDL was only 62 and whose HDL was 45, and maybe it just wasn't the right population to study. The CETP inhibitor studies, one was with torcetrapib, raised HDL by 60%, lowered LDL by 20%, but it had serious off-target effects. Probably the worst of which was an increase in endothelin-1 in the artery wall, which overrode any potential benefit. The other, dalcetrapib, was in people immediately after an acute coronary syndrome, where the HDL was not functional. In fact, in that trial, even the placebo group, the HDL did not predict events. So we don't know. The good news is that we have studies with anacetrapib and evacetrapib that are ongoing in large clinical outcome trials that will report probably around the end of 2016, beginning of 2017. So that will tell us whether or not these agents are going to reduce cardiovascular events. But one very interesting thing is there is a new CETP inhibitor called TA8995. The first of the papers is in Press in the Lancet. It has a massive 50% reduction in LDL, a big increase in HDL cholesterol, but most important, increases HDL function. It increases the ability to promote cholesterol efflux by about 50%. So I have moved from being pessimistic about HDL to being less pessimistic to now actually having some optimism.
Okay, well, HDL is, as you say, has been pretty much ignored because we're focusing so much on the new LDL methodologies, with the PCSK9 inhibitors and so on. And yet, if we treat a patient with a statin, we almost always have success in total and LDL cholesterol, and oftentimes not much success in HDL cholesterol. So there's obviously other pathways that have to be dealt with. And I know, particularly in the population I see, an inner city urban population with a lot of diabetes and obesity, that the triglycerides are elevated and the HDLs are very low. So there's another metabolic component. Now, how do you deal with patients in that kind of a milieu with obviously metabolic derangements that are causing low HDLs? Are you successful at all with advice about managing diabetes, advice about weight loss, and so on?
The first thing is they must have statins, and we know that even in that group, statins are very, very effective. But there is a residual risk which is quite profound. At the moment, we don't have effective HDL-raising agents. We do know that in that population, fibrates added to a statin can reduce cardiovascular events, but it's probably not by changing HDL or triglyceride. It's just that that phenotype identifies people who benefit from fibrates. Niacin was hoped to be beneficial, but most people have problems taking niacin, and the recent trials, even though there were problems with the trials, will probably say that niacin will slowly disappear. The big hope is that the CETP inhibitors will come, but at the moment, absolutely stress lifestyle. Lose weight, keep that weight off, be physically active. Do that, and you even have the potential to prevent progression to diabetes or even reverse diabetes, certainly get it better controlled.
Right. And, we always used to tell people that alcohol raised HDL. So how do you deal with that? Do we still have that data that suggests that a certain amount of alcohol does benefit HDLs?
There's no doubt alcohol does raise HDL. We have no idea what it does to HDL function. But the big problem is that the level of alcohol that has a big increase in HDL also does some rather nasty things to the liver. So I don't think that we should be promoting alcohol to raise HDL.
So we're not telling people to start drinking more alcohol. No. I think that's encouraging information because we're trying to follow that pathway anyway. The other thing that's come out is that all HDL isn't the same, that there's good HDLs and bad HDLs. Can you tell us a little bit about that?
HDL is very, very complex. At last count, there were something like 37 identifiable subpopulations that migrate in the HDL range. HDL carries a very large number of additional proteins, the functions of which we don't really know a lot about. But the problem is, while there are many functions of HDL, there are many subpopulations of HDL, we don't know which functions are clinically important, and we certainly don't know which subpopulations are. We have clues, but then we have another paper showing something different and something different. At the moment, there's a group, small group, but doing very basic research, looking at each of the individual subpopulations of HDL and relating them to function, and also trying to develop tools to measure the concentration of these subpopulations to go back to the clinical trials and the epidemiology to see which of them really are predictive. At the moment, we just don't know.
Our usual lab slip is HDL, total triglycerides, and total cholesterol, and then a calculated LDL. Is that pretty much the way you folks behave in Australia as well? Do you get the big three numbers and then calculate LDL for the most part to manage lipids?
We do, but there's a group of us arguing very, very strongly that there is more atherogenic lipoproteins than just LDL. In fact, it's all of the cholesterol that's not in HDL. We call it around the world non-HDL. It's a bad term. I'd like to call it atherogenic cholesterol. That is what I think will become the standard investigation. And it's easy because all you need is the total cholesterol and the HDL cholesterol and the ability to subtract one number from another.
Right. Sometimes I wonder about that ability, but the fact is that we've seen European and Australian guidelines focusing more on non-HDL cholesterol, and I think you've explained why. I think it's a very easy number to get, number one, and number two, it has a lot of relationships to risk.
And in fact, it's turned out when it's been looked at, it is a better predictor of risk than LDL cholesterol.
And I think the way we get our lab data now in the States, and I'm sure elsewhere, is we do get the numbers to calculate non-HDL cholesterol. So I think your message is we should be looking at that number and even getting our patients used to that number rather than just the LDL number.
In fairness to the people who are holding on to LDL, I agree with them that if we make a sudden change, this will cause great confusion. So at the moment, everybody says, yes, LDL's a target, an alternate target is the non-HDL, and with the passage of time, over the next probably 3 to 5 years, I think that the non-HDL will replace the LDL.
A boundary number for non-HDL, what's a good number, 120, 130?
Probably add 30 to the LDL goal and you're there with the non-HDL.
Okay, about 130 then would be a good number. As you say, it's a simple subtraction of two numbers. Most people should be able to do that easily.
And even better, it usually does not require a fasting sample.
Oh, that's another very important thing. Yeah, you're right. You can do a random sample for that as well. It's been very informative. I think your insight into the lipids in general and encouragement about HDL is very helpful, and I think we'll look forward to some of the HDL trials. But in the meantime, we should get used to non-HDL cholesterol as a measure and start instructing our patients on the same, because that's a valid thing to do today, actually.
And to encourage better lifestyle.
Oh, yeah, for sure. Good. Well, thank you very much for being here.
My pleasure.